Hello, it's Anthony Chadwick from the Webinar Vet, welcoming you to another episode of VETchat, and this is during our Oncology mini-series. I'm really pleased to have Owen Davies on the line. Owen is the head vet of the Oncology service at Bristol Vet Specialists, which is a CVS practice based down, funnily enough, in Bristol. It's always good, I think. Previously, in previous times, Owen, you couldn't actually say where you were based because it was deemed as advertising by the Royal College.
Oh,
So the
okay.
world has moved on, hasn't it?
Mm.
But it's really great to have you on. Perhaps for those people who aren't familiar with you, and of course they should be, because if they're listening to Webinar Vet webinars, you've done many webinars for us, and really appreciate your help with those. But for those who perhaps aren't as familiar, perhaps you could just give a little intro about your history, your back history as a vet, and so on.
Yeah, sure. Well, I've been a vet for almost 20 years now. And in the first half of that, I was a general practitioner. Started off in mixed rural practice, doing a lot of large animal work, and I progressed slowly into small animal work, working through charities for a few years, and then a kind of progressive small animal practice. And then in the last 10 years, I've been doing oncology referrals. I was a resident at the Royal Veterinary College for 3 years. And since then, I worked at Highcroft Referrals, which last year rebranded and moved to a new site and became Bristol Vet Specialists. I'm now a registered specialist in oncology in the USA, UK, and Europe. And I lead a small team of one other specialist, 2 residents, and a group of specialised nurses where we treat cancer in cats and dogs in Bristol.
Oh, and I think it's really interesting. Obviously, you came from a GP background, and that must give you a sort of extra perspective, perhaps, than if you'd immediately gone into university and residencies and internships and then lecturing and so on. What do you think that brings to you, that sort of knowledge of what GP life is like?
Yeah, I think that's very helpful. When people are trying to refer cases, often that they found very difficult, or perhaps they felt they could have done with a bit more support in working up, I feel I understand that. I feel I've been there. I also feel that, fundamentally I'm a vet first and foremost. I may be an oncologist, but first and foremost a vet, and I don't want to lose that. I want to be able to triage an animal with a broken leg and provide appropriate analgesia and bandaging, for example. I'd like to think I could work up and treat appropriately an animal with heart disease or chronic diarrhea at a GP level, not trying to be a specialist or anything.
Yeah.
So
Yeah.
I want to continue to be a good all-round vet, or as good as I can at least.
I think also interesting at Bristol Vets, you're a multidisciplinary team. So that must also be useful, that when you're seeing cases, oncology affects every single system, doesn't it? From the brain, neurology, skin, obviously the blood system, liver, gastro. So to have that, I suppose, do people refer in with oncology usually, or do you find that you're also getting a throughput coming back from the vets who, are referral vets in your practice as well? It's a two-way street, presumably?
Yeah, we do get quite a few cases. For example, brain tumours, CNS tumours, often come through neuro first, because they might present as an animal who's just seizuring.
Yeah.
And when we started, 7 years ago at Highcroft Referrals, I was the first oncologist in the area. And a lot of people weren't used to referring to a dedicated oncology service, so we used to see a lot through medicine and surgery. Now I think our surgeons and our medics are quite pleased that a lot of the cases will come straight to us first, and we involve other disciplines where needed. So probably 80-90% of what we see is straight to us.
Yes.
And another 10% is through other disciplines like neuro, ophthalmology, dermatology, etc.
And obviously you did a master's, I think, around lymphoma. That is kind of our bread and butter tumor that, if you like, people in general practice will have a go at. I mean, have things now moved on should we still be treating lymphoma in practice, or is it something that you would really recommend referring across? As much as anything, it's also the health and safety of drugs. We've got to be really careful how we deal with some of these drugs as well, haven't we?
Yeah, I think in principle, there's no reason why lymphoma shouldn't be treated in practice at all. That said, it does take quite a lot of work behind the scenes. As you said, we need to make sure drugs are being used safely.
Yeah.
And to use drugs safely, you need three things. You need the drugs to be drawn up in a fume cupboard.
Yeah.
They need to be administered with a closed system transfer device to prevent spillage or aerosolization. And you need chemo-tested PPE, like gowns and gloves and eye protection, etc. So those three things. It may sound daunting, but the fume cupboard doesn't have to be in your practice. The fume cupboard could be in someone else's practice, and there are services now that will be able to send you drugs with a courier after drawing it up in their fume cupboard. And there's more than one of those. And those services will also be able to provide closed system transfer devices and PPE. So it's very doable thanks to such businesses. The other thing you need to do in practice is make sure that people who are pregnant or nursing are excluded from administering or dealing with chemo. If we use the fume hood, the PPE, the closed system transfer, etc., then they shouldn't actually be at any risk, but we're being belt and braces, so we exclude people who are vulnerable, the pregnant and the nursing. And we need also to think about where in the practice the treatment is administered. We don't want a large throughput of people walking.
Yeah.
We want to make sure it's got all the IV stuff we need, all the stuff to remove the IV safely, and all other drugs to be given around the same time, like meropitant. So we don't want people running across the practice wearing PPE and running back again.
Yeah.
So it needs a little bit of thought and a little bit of planning, but it's otherwise very doable. There's various recipes that can be used, the CHOP protocol, COP protocol, widely available, widely described, and a lot of practitioners are quite well versed in doing these.
Has sort of lymphoma treatment moved on though, or do you think we're getting better and becoming more personalised in the way that we treat it because we understand the biology of the tumours better? Because obviously lymphoma is a big term, and there's lots of different stages and types, aren't there, and so on.
No, you're absolutely right. Some lymphomas are very easy to treat, others are extremely hard. And that underlines the fact that it's a group of at least 30, if not as many as 50, 55 different diseases.
Yeah.
Lymphoma in that sense is a misleading term. What we should be doing in practice is recognising the lymphomas that are low grade and the lymphomas that are high grade.
Yeah.
And most of the ones we see, the typical dogs who come in with suddenly very large lymph nodes everywhere, they're going to be high-grade diseases.
Yeah.
But there are a significant minority that are low-grade diseases, and these guys may not need treating. They might just be cases that you monitor. And you think about treating perhaps when disease is more advanced. The other thing with the common high-grade diseases, it's very helpful to determine who's a B cell and who's a T cell. And if you can, within that, you can break that down to other subtypes of disease. For example, the T lymphoblastic lymphoma is actually very aggressive, tends to have a very sad prognosis.
Yeah.
The other high-grade T-cell lymphomas are still very aggressive, but less so. And some of the B-cell, diffuse large B-cell lymphomas are these cases who may live for a few years in some cases and can do really well on chemo. So knowing that prognostic information is useful, not least for owners' peace of mind and preparation, but for planning the kind of treatment that's going to be needed. Some of the T lymphoblastic cases benefit from a very aggressive treatment straight away. They're often sicker animals. They might need hospitalizing, for example. But some of the other substage A, the healthy B cell and T cell high grade lymphomas, you could treat quite happily with a COP or CHOP protocol. There's some evidence now to support use of a different protocol in the T cell high grade lymphomas, and that's what we do in our practice. We tend to use lomustine-based treatments like LOP or PLOP compared to the traditional CHOP. The increasing support says that the CHOP protocol works best for the high-grade B-cell cases.
Talking about T lymphocytes, it was one of my areas of interest as a dermatologist was epitheliotropic lymphoma, and obviously was obviously a treatment there as well. Part of the problem also is this reactive lymphocyte compared with a neoplastic lymphocyte can actually be quite challenging for pathologists to recognise that. And actually, I had a dog who had some lip fold pyoderma or lip fold lesions, and I took them out and I decided to send them off to Trevor Whitbread. And he came back and said, oh, this is epitheliotropic lymphoma. And my cases of epitheliotropic lymphoma used to be, oh my goodness, referred to me, were really sort of poor prognosis and usually fell apart within sort of 4 to 6 months on various treatments. But the dog actually lived for several years and didn't really die of his epitheliotropic lymphoma. So I think, as you say, with all of these diseases, there is a big gradation, isn't there, of severe to very mild, presumably, and those ones probably are not spotted because people notice a bit of redness, put them on steroids, and they actually do rather well just on that sort of intermittent treatment.
Yeah, I think epitheliotropic lymphoma is a really good example of a disease that's quite hard to study. Because if you're studying these cases, you tend to recruit at the level of the pathology lab where all the biopsies get sent, and you can get a list of the diagnoses with epitheliotropic lymphoma. But what that doesn't tell you is the severity of clinical signs and the proportion of surface area of the animal that's affected. Because you could have one really aggressive looking lesion histologically, but if it's just one lesion, it could easily be removed and the rest of the animal's fine. And then you could get the animals that are just bright red and no amount of steroids or other treatment will control their pruritus and their clinical signs. And histologically, they might look very similar, but one is actually much more advanced than the other. And it's even on clinical notes, it's very hard to quantitatively say how much the animal is bothered by this or how much surface area is affected. And I agree. There's a couple of good studies now that have shown that the lip fold pyoderma, the kind of mucosal epitheliotropic lymphomas that don't affect the skin, will usually do a bit better than the ones that are multifocal or ones that have a large amount of skin affected.
Fantastic. Where would you say that the sort of big advances are in oncology with regard to some of the screening tests that we're seeing? Are they proving to be useful for you?
Now, I have to say I haven't used any of these liquid biopsies or other tests that are currently being rolled out myself. I think potentially they could be very useful because dogs and cats are tough and stoic, with a few exceptions that we all know of, I'm sure. Yeah. But generally, as species, they don't tend to tell us much. You or I might go to the doctor if we're feeling a bit weird or something's not quite right. And to be able to detect a lot of cancers in cats and dogs, they present when advanced. The value of the yearly health check is great for a lot of things, but for detecting cancer, the sensitivity is quite low. It's only 4% of cancers or something like that are detected at a yearly health check. 8% of cancers are detected incidentally, and pretty much all the rest of them are detected at quite an advanced stage when the animal's presenting with clinical signs. And I think we all have experienced times in practice when we thought, I had no idea this was going on, but we have a very, very advanced cancer now. If only someone could have accidentally x-rayed this dog a few months ago, we might be able to do more about it. For example, an osteosarcoma presented when pretty much all the bone's been destroyed, and you can think of all the micrometastatic disease burden the dog's going to have. Or a hemangiosarcoma that presents with a hemoabdomen, or the anal gland tumour that presents with disseminated disease, or at least very large regional lymph nodes, and the dog can't defecate. If we could pick them up at an earlier stage, it would be a better prognosis and much more affordable for our owners to deal with these things. So I really applaud the idea of trying to be able to screen for these things and pick them up sooner. There's lots of different screening tests available. Some of them use microsatellite DNA, some of them use next generation sequencing, some of them have looked at using nucleosomics. But the premise is that cancer cells are very easily broken, and where there is a tumour, there'll be cells breaking, releasing molecules into the circulation. And as it happens, DNA tends to be a very, very stable molecule, one of the most stable molecules in the world. And so you could do a blood test to check for floating bits of DNA from a tumour. Some of the data I've seen so far has got some very impressive results. But when you break it down into the tumours that I'm mostly interested in picking up early, the osteosarcs, the hemangiosarcs, the sensitivity for them is perhaps not as amazing as I'd like. And the sensitivity for some tumours like mast cell tumours that are more obvious and can be found on a skin exam is actually higher. And that tends to pull the data up. But there's lots of different companies working on it, lots of different techniques, and it is getting better year on year. So I think in the future, just like the screening tests for prostate cancer in men, I think this could become much more useful.
I think it's one of those things, if you don't start on a pros test, then you're not going to improve. So
Yeah, exactly. Yeah.
start somewhere, don't you, with a test that perhaps isn't ideal but has some use, and then develops, with time and with usage and so on. You were talking about osteosarcs. Where are we at with those now? What kind of is the ideal treatment for an osteosarcoma? Because there was always a lot of controversy about, drugs like cisplatin. Do you amputate? Don't you? Etc. Etc. So, where are we at with some of these bone tumors?
Yeah, with osteosarcomas, I tell my clients we need two treatments really. We need one to deal with the local disease and the pain, and we need a second one to deal with the metastatic disease.
Yeah.
And even at a small size, a very small size, we'll have to assume that a primary tumour will have seeded lots of microscopic mets, often in the lungs, but could be lymph nodes or other bones. So we need a local treatment, and then we need a systemic treatment, basically. And because of the advanced stage at which most osteosarcs are picked up, amputation is usually the mainstay of local treatment. And because of the spread to other parts of the body, chemotherapy has to be the mainstay of treatment there. Now, there's a lot of research going on into osteosarcoma because it's a very good model for pediatric bone cancer. And particularly in terms of controlling metastatic disease, there's been a lot of interest in finding an immunotherapy. Osteosarc is a very immunogenic cancer, so there's a lot of interest in trying to wake up the immune system to try to target it. And so there's been some interesting data published so far, either with chemotherapy or just as a sole immunotherapy. I'm afraid I'm not aware of any of these immunotherapies that are available commercially, and some of them have had quite marked adverse effects. So that resulted in the project being put to one side. But
Yeah.
at some point, we will hopefully get a useful immunotherapy that can be used either instead of or along with chemotherapy for these. And so for you and me in our practices at the moment, the mainstay of systemic therapy would either be carboplatin, which is much, much safer than cisplatin, much kinder to the kidneys, usually a very well tolerated drug. Or you could use doxorubicin, which is just as good, but more likely to cause diarrhea, and in some dogs has a risk of cardiotoxicity. And that would be the mainstay. With regard to the local disease, as I said, amputation's the main thing if we can.
Yeah.
If we can't do amputation, then palliative radiation therapy is a very good way of not treating the tumour, but killing those pain receptors, if you like, and making the leg much more comfortable. And there is a company called RCVS who have introduced a cementoplasty product, which is where you've got a load of dissolved bone due to the tumour. You can inject into the tumour a bone cement, which will kind of hold things together. And they claim that it has been able to stabilise the bone and also reduce the associated bone pain with a gross osteosarc. Now, I would always try to amputate if we could, but for those few cases, important few cases where amputation is not appropriate, things like palliative radiation or the cementoplasty may be very useful.
Obviously, Buddy's here. He's feeling that you're talking too much about dogs.
Yeah.
So, have you got anything you want to tell him about cats that he should know?
Cats are brilliant because the more we learn about oncology or veterinary medicine in general, the more we realise cats are different.
Hmm.
And if we're talking about lymphoma like we were a minute ago, it's remarkable how difficult the prognosis with feline lymphoma can be to predict. People have looked at all kinds of clever ways of trying to gauge prognosis, and the effect has been shown to be quite weak. And people might intuitively think that if a cat is very, very poorly at diagnosis, their prognosis would be much worse. And that's certainly the case for dogs. But it isn't necessarily for cats. The only thing that tells us if a cat is going to do well on treatment for lymphoma is response to treatment. Regardless of what treatment you use, that doesn't matter so much. I would look to restage them, image them thoroughly after 3 or 4 weeks and ask the question, have we got a complete response where the disease has vanished? Or have we got a partial response where the disease is reduced, but still you can find it? And if you haven't got a complete response, I would look to change treatment to try to make sure that we do get that, to give them every chance of getting that complete response. And some of these cats who are getting to a complete response quickly, they'll live for several years.
Yeah.
And against all the odds, you might get a renal and CNS and gastrointestinal lymphoma all at once, and the cat's really poorly, and the owner's almost going to put them to sleep. But you thought you might try treatment, and within a month they're much better, and you're still seeing them for vaccines 2 or 3 years later.
Fantastic.
So
And
it's
what sort of
well worth
treatment are
treating
you
them.
using for lymphoma?
Personally, I start with the traditional COP protocol.
Yeah.
Because no one's been able to definitively show that anything's better than that. If my cat isn't responding so well, I'll make it a CHOP protocol, or I might add in lomustine if costs are an issue and make it a LOP protocol. Just adding more agents gives them more chance of the complete remission.
Fantastic. Just a final thought on antibody therapy. You mentioned it with the immunogenic treatment. Obviously difficult at the moment in the UK because of the whole cascade system, but I know more of that is going on in the States, isn't it?
Yes, now that's some really exciting advances have been made in the last few years because the antibodies, humanized antibodies, have been used in human medicine for some time alongside chemotherapy, often to target cancer with specific mutations, specific genomic patterns. And we just haven't got the funding to be able to do that on a widespread basis. But there are a few things coming along line which I'm very excited to see rolled out into the UK. One of these is a drug called Gilvetmab, which I believe is made by MSD and currently has conditional license from the USDA in the States. Now, this particular drug is a caninized, hear that, caninized monoclonal antibody. So we have a minimal risk of anaphylaxis or hypersensitivity because it's a special dog antibody against an immune checkpoint. And we've realized recently that the job of doing well in cancer treatment is not just killing cancer cells. Cancer cells are the body's own cells, and if you kill enough of them, you'll often cause a hell of a lot of collateral damage with the body's own cells. The often the secret in getting a really good outcome for a cancer is getting the immune system on side, getting the immune system to recognize these cells that have been flying under the radar and causing all kinds of damage. And the way that has become quite popular of trying to modulate the immune system is by modulating these immune checkpoints. Making an immune response is often a very finely balanced decision that the immune system has to make, because you don't want inflammation going on all the time. You'd get unacceptable and life-limiting immune-mediated disease. At the very, very least, you'd get inappropriate inflammation that would get in the way of wound healing and epithelialization of just a cut or something. So the immune system has to say what definitely needs to be addressed and what doesn't, and when to start and when to stop. And it's a very finely tuned thing. And it does this, well, one of the mechanisms by doing this is these immune checkpoint molecules. To make an immune response, the immune system needs enough evidence from the cytokines or the cellular damage or the cellular background to say that an immune response is needed. And the cancers are very, very clever. They will often produce molecules that will specifically address these checkpoints and turn off the immune response. So Gilvetmab and other antibodies that have been used like it will bind this receptor on the T cells and prevent it from being inactivated by the cancer's ligands. And it means that an immune response that would otherwise be turned off is allowed to proceed. So that's very, very exciting. And in the USDA, they have conditional license for treatment of melanoma and mast cell tumours at the moment.
Fantastic. It's great to see that, as always, medicine continues to advance, but oncology has had such a massive advancement when you think, human and animal over the last 20, 30 years. And really interesting to hear about these very much more targeted and personalized treatments as well, which is when we were treating with prednisolone alone, it was a bit sort of hammer, a sledgehammer against a small nail, wasn't it? Because it doesn't just affect the tumor, it affects everywhere else as well.
Yes, yeah, absolutely. Yeah.
Owen, thank you so much for coming on. It's always interesting to hear what's going on in the oncology world, and hopefully we'll see you soon on another podcast or webinar very soon.
Yeah, should do. Thanks ever so much for inviting me.
Thanks, Owen. Thanks everyone for listening. This is Anthony Chadwick from the Webinar Vet, and this has been VETchat. And we hope to see you very soon on another podcast or webinar. Take care. Bye-bye.